Good evening, all. Thanks for the organizers for calling me for this conference. The topic for me is algorithm for assessment of MSLD in patients of diabetes. Prior to me, doctor has already talked about the pathophysiology behind MSLD. It makes my talk further easier. MSLD and diabetes are both one of the most prevalent metabolic disorders, which often coexist and exacerbate with each other. Both the diseases key mechanism being insulin resistance, inflammation and lipotoxicity. Around 800 million individuals have a prevalence of diabetes in year 2024, and which is projected to be 1.23 billion by year 2050. Again, like in the previous speaker slide, the incidence of MASLD in India is around 40%, and same is the case worldwide. So the terminology of liver fat accumulation over the last few decades have evolved significantly from fatty liver to non-alcoholic fatty liver to MASLD. Initially, Ludwig et al. In the year 1980s suggested the term non-alcoholic fatty liver disease, and the paradigm shift to MASLD marks the pivotal moment in emphasizing the metabolic origin of these diseases rather than a stigma of fat or alcohol. So the metabolic dysfunction associated steatotic liver disease is a steatotic liver disease wherein there is presence of one or more cardio metabolic risk factor, which doctor has already highlighted upon in the previous slides, which includes obesity, presence of diabetes or under treatment of diabetes, hypertension or under the treatment of hypertension, dyslipidemia, all play the role in labeling a patient MASLD. The pathophysiological pathway, I'll not go into much detail. The disrupted glucose metabolism and accumulation of harmful lipid byproducts leads to adipocyte dysfunction and leads to further increased cytokine production, which leads to fatty liver. These days, bile acid receptors studies are ongoing. The FXR and TGR5 receptors of bile acid metabolic pathways also implicate impaired glucose and lipid metabolism, which further leads to fatty liver. In Indian subset of population and the Asian subset of population, the gene PNPLA3 is highly prevalent in diabetic patient, which progress over to MSLD. When there is an energy intake which exceeds our metabolic needs, the excess carbohydrates changes into liver into the free fatty acid. Similarly, when the adipose tissue limit is crossed over due to excess intake, these free fatty acids release some lipotoxic lipids like diacylglycerols, causing some oxidative stress, inflammation, and further progression into fibrogenesis and cirrhosis of the liver. Usually most of our patients are asymptomatic, or they may present with some amount of unexplained fatigue or right upper quadrant discomfort. In such cases, we must go into detailed family and personal history related to liver disease and diabetes, and exclude secondary causes of steatosis like some drugs or alcohol intake. There must be a detailed evaluation of BMI, waist circumference, ruling out hepatitis B and C infections, lab parameters including LFT, CBC, and ultrasonography and lipid profile. The diagnosis of MASLD is based on detection by ultrasound of more than 5% hepatic steatosis, which is the first step to trigger further evaluation of such patients to divulge the severity of MASLD. Though liver biopsy is the gold standard method to determine the liver fibrosis, though being it invasive and a costly test, non-invasive test comes into play, which are less invasive and a better alternative to liver biopsy in our clinical settings. Variety of non-invasive tests are available in the clinic settings, which may include from simple scores like NFLD fibrosis score, FIB-4 score or APRI score, or some proprietary serum test like enhanced liver fibrosis test, which is available in UK and Europe, and imaging techniques like fibroscan or MR elastography, which I'll divulge into little more detail in further slides. A good non-invasive test must be both specific and sensitive to determine the presence or absence of liver fibrosis. They have a lower cutoff value which maximizes the sensitivity of this test, ensuring that we don't miss patient with any advanced fibrosis. Similarly, a upper cutoff value will maximize the specificity of the test, ensuring that we don't misdiagnose patients with advanced fibrosis. Fifth four is the fibrosis 4 score, which we can calculate in our clinical settings, wherein we take it is all available online. Age, AST levels, ALT levels, and platelet count are taken into consideration. A threshold value of less than 1.3 is sensitive enough by 82% to exclude fibrosis in such patients. Similarly, a value of 2.67 and above is specific 93% to label a patient to have advanced fibrosis, and it should warrant a hepatologist referral for further evaluation of such disease. And similarly, NFLD fibrosis score is calculated in addition to AST, ALT and platelet count. We take into consideration the BMI of the patient, albumin levels, and diabetic status of the patient. The threshold value of minus 1.455 to more than 0.676 have been suggested to be sensitive and specific enough to diagnose a patient of advanced liver fibrosis. Further on, moving to the scanning part, the fibroscan. In this, it's an ultrasound attenuation wherein we check for steatosis by checking the decibels or controlled attenuation parameters in decibels, or the liver stiffness measured in kilopascal, which suggests fibrosis. The best cutoff value reported for fibroscan have been reported by Carlos et al. Using the AMPRO with values of 248, 268 and 280 decibel per meter, labeling the stage 1 S1 steatosis, S2 steatosis or S3 steatosis respectively. In liver stiffness measurement, it measures liver surface, liver stiffness over a broad area, at least more than 100 times from as compared to the liver biopsy sample. But it may overestimate fibrosis in cases of hepatitis, cholestatic liver diseases or some mass lesions. So we should always have a high degree of suspicion if the values are very high. Again, different guidelines and societies have recommended the lower cutoff value of less than 7.9 kilopascal to be sensitive enough to exclude patients with advanced liver fibrosis. Again, a non-invasive test evaluation with a low result of NFLD score of minus 1.455 and below, FIB4 below 1.3 or liver stiffness measurement below 7.9 kilopascal is sufficient enough to confirm the absence of advanced liver diseases in patient of diabetes. Currently researches are underway utilizing MRI, proton density fat fraction, especially in evaluating the efficacy of drugs. It is under clinical trial, and it said that if there is more than 30% relative reduction in MRI PDFF between the baseline values and post-treatment values, we achieve the objective, and this drug can be used in treatment of MSLD. It is the gold standard test to quantify hepatic steatosis and is a promising surrogate to liver biopsy. As recommended by American Association of Study of Liver Diseases and European Association of Study of Liver Diseases, every patient of diabetic must undergo a non-invasive liver fibrosis test. The preferred test is FIB4, which is quite convenient, utilizing just 4 parameters: age, ALT, AST and platelet values. If the value is less than 1.3, then we just need to clinically monitor the patient every 1 to 3 years, unless and until some clinical variations happens and his diabetes worsens. In case the value is above 2.67, urgent referral to hepatologist should be considered to evaluate for further causative factors leading to such advanced fibrosis at the initial stage. In case the values are indeterminate between 1.3 to 2.67, we may order a liver stiffness measurement by doing a fibroscan, wherein value of 8 kilopascals are labeled to be a low risk, and above 12 kilopascals, again it's a high risk case. Again, when to I have already highlighted this part, that when to refer to hepatologist. Advanced fibrosis assessed by FIB more than 2.67, a family history of HCC and a clinical evidence of cirrhosis. Even though FIB4 remains the most clinically validated NIT test, there are some further validated markers like APRI, ELF score and MRE. APRI is aspartate aminotransferase platelet ratio index, can be calculated bedside with cutoff scores of less than 0.57 to 0.84, though it is less sensitive and specific as compared to the previous parameters I have explained. Enhanced liver fibrosis test is a blood test that provides an estimate of liver fibrosis by testing the serum markers like hyaluronic acid, PIINP and TIMP1. ELF scores between 7.7 to 9.8 are indeterminate to moderate and should increase the clinical suspicion of advanced fibrosis. MRI elastography has been shown to be both sensitive and specific when identifying the different stages of liver fibrosis. Liver stiffness values on MRI by less than 2.97 to 3.62 have been propounded to be specific enough. 83% of patients we can not miss by this value. Ending my talks with some take-home points that FIB4 is a well-validated and easily accessible test. We all clinicians should undertake this test in our clinics for every diabetic patient. A patient range 36 to 65 years old. If FIB4 is 1.3 or those older than 65 should undergo a fibroscan. MRI based test can further risk stratify our patients. Liver biopsy in the end may be considered if there is high clinical suspicion of cirrhosis or there is diagnostic uncertainty. Thank you.